This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended.
She is an 85-year-old lady who has this corneal opacity, pseudoexfoliation, and nuclear cataract. The cataract is about grade 3 sclerosis, and the corneal opacity is not complete. It's in about 1/3 of the quadrant, but is in the center of the cornea. But I still have certain clear areas for me to visualize well and perform the surgery. Now, because this was pseudoexfoliation and non-dilating pupil, so my plan is to go ahead with the BX device and try to perform a slightly bigger excis, emulsify the nucleus, and if need arises, put in a CTR and then the planned lens into the bag. So some of the major challenges which I'm expecting this patient is, number one is obviously going to the poor visualization. That is because of A, corneal opacity, B, small pupil. Apart from that, because the patient is quite old and also having pseudoexfoliation, I'm not sure about the zonular health. Zonular weakness, if it is, it's a major concern and it's going to make the surgery much more difficult. Nevertheless, I'm ready with all these thoughts in my head and let's see how things turn out. The incisions are created, the capsule is stained, OVD is put into the eye. And because I'm expecting some complication, I'm consciously making a scleral incision. If the need arises, then I may enlarge this and make it into a sclerocorneal tunnel to deal with the situation. Now, because this is a rigid pupil, I prefer to stretch the pupil before putting the BX device. So I'm using 2 Y hooks to engage the pupillary margin and stretch it across. This will make it less rigid and hopefully I'm going to get a better mydriasis when I use the BX device. I typically stretch the pupil in 4 different directions, diagonally opposite, and Y-hook is a great instrument to have where you can engage the pupillary margin and then stretch it. I usually avoid doing extreme stretching, that is going cross limbus to limbus. Prefer to do it about say 80 to 90% up to the limbus and not beyond that. Once the stretching is done, time to place in the BX device. Time to perform the rhexis. The capsule is punctured and the capsule is begun to tear. At this point, there are few folds but not very much significant, suggesting that the zonular health is reasonably alright. Of course, it is not in great health, but definitely not to be alarmed of. So Phaco could be performed quite easily. That is my assumption or thought process which is going in my head right now. As the rhexis is being completed, the BX rings get entangled in the forceps and a couple of notches get disengaged from the pupil. So again, it has to be refixed and it is done, and now time to perform hydrodissection. I believe hydrodissection is a very important step in all eyes who have got pseudoexfoliation and we're expecting zonular weakness. It's important that the corticocapsular adhesions are totally freed up before we start maneuvering the nucleus around. Once the rotation of the nucleus confirms this, now is the time to proceed with phacoemulsification. The nucleus is being divided into multiple small fragments using the vertical chop technique. So far so good. The case is going on pretty well. No surprises at all. The nucleus is around grade 3 and once the fragments are made, each of them is maneuvered out of the bag and emulsified at the level of the rhexis margin. So it looks to be alright. I think all the major challenges are handled well. It's just the time to remove the cortex and put in the lens. So this is when the life teaches us a lesson that never take anything for granted. So it looks as innocuous cortex aspiration to be done as if now. As I'm trying to go in and engage the cortex and try to remove, suddenly something unusual happens and you can literally feel the oops moment going in your head. Okay, something has gone wrong. So now I realize that what I'm catching now is a vitreous fibril and obviously the C-shaped demarcation line is the PC tear. No, how did it happen? When did it happen? So let me go back and rewind and just show you. So and I'm trying to move in. This part of the PC is slightly protruded out and as the cannula goes towards the equator of the capsular bag, this is where it is held the posterior capsule, and as I'm moving around with this thin capsule which is very friable, it just torn, and by the time I retract the probe into the central safe zone, already there is vitreous fibrils entangled in the port. The first thing to do is always press reflux here reflex doesn't work in a single shot. You need to press multiple times, and sometimes even after multiple pressings also it may not spit out the contents, and you need to use a second instrument to disengage and finally pull out the probe. Well, obviously the vitreous prolapse was quite evident here, so I didn't want to use triamcinolone acetate at this stage, maybe later. And you can also see that the posterior capsular tear is demarcated out. It's slightly pushed to the right side, and you can see the extent of the tear as well. So time to perform the anti-vitrectomy. The vitrectomy is begun usually with the port facing down first and then sideways, just to clear off all the vitreous which is at the level of the PC tear and also from behind. This also ensures that you cut out all the connections with the vitreous which is prolapsed anteriorly. It takes a couple of minutes for us to clear off all the vitreous. Now remember, this case, we were struggling with visualization before itself, and to add on to that we have another complication of PC tear. Nevertheless, in a couple of minutes the vitreous is taken care of. And how can we tell that the vitreous prolapse in the anterior chamber is no more? Well, just look at the shape of the posterior capsular tear. It was pushed way back to the right side initially. Now once the vitreous is taken care of, the tear has become much more linear and the lateral push has gone. So these are the signs which are indicative of the prolapsed vitreous now being taken care of. So once the vitreous is totally clear of the anterior chamber, now is the time to remove the remaining cortex. So one quadrant still has significant cortex. I swap the instrument with an bimanual I&A and use the aspiration cannula of the bimanual to aspirate out all the cortex. Now is the time to place the lens in. The plan is to place a multi-piece lens in the sulcus and then hopefully achieve an optic capture. The real challenge here is poor visualization because of the corneal opacity, and also a couple of areas the rhexis is slightly bigger and a few areas rhexis is smaller. And the rhexis is exactly at the size of the pupil. So I need to be very sure that the haptic is above the capsule and not under it. So I am creating some space using a cohesive OVD like the sodium hyaluronate by placing it above the anterior capsule and under the iris so that the space is created. But there's still a lot of drama to happen. Although I'm very conscious that I want to place the haptic above the capsule, something else happens here. Consciously, I've placed the haptic on the surface of the iris. Then I'm using a micro forceps to gently hold the haptic and guide it just under the iris and above the rhexis margin. At this stage, I believe that it is above the rhexis margin. Time to place the second haptic into the sulcus. I'm trying to use the rhexis forceps itself to gently maneuver the second haptic above the anterior capsule. At this stage, as the lens is rotating, I realize that the first haptic is in fact not above the capsule but is under the capsule, and the lens is almost ready to nosedive into the vitreous. So the first thing to do now is to pull back the lens. So again, I'm going to resort to my micro forceps. This is the same forceps which I used to place in the B-hex ring. This is the B-hex forceps. I'm using this forceps to hold the haptic, pull the lens out a little bit, and then place this trailing haptic outside the eye itself all the time. So now is the time I have to go in, hunt for the other haptic which is slipped behind the posterior capsule, hunt it out, and then again maneuver it anterior to the anterior capsule. First, using two Synskukes, the optic is gently maneuvered anteriorly so that it is lying in the anterior chamber. Then again a little bit of OVD is used to create some space. The distal haptic is now gently maneuvered over the anterior capsule. The trailing haptic is then dialed into the sulcus and over the anterior capsule. So now I'm pretty sure that both the haptics are in the sulcus, and it's unlikely now to dive into the vitreous cavity. The notches of the B-hex device are disengaged and the ring is removed out. Now before I introduce my vitrector to remove the OVD behind the lens, I'd like to share a very important tip at this point. Now before introducing the irrigation cannula, just be mindful that the bottle height is reduced significantly. Now because remember, the situation is there's an open posterior capsule and we already have done a limited antivitrectomy. So whenever the sudden infusion starts in, the fluid from the antechamber has got direct communication to go through the posterior chamber. Whenever the infusion kicks in, there will be a sudden deepening of the anterior chamber, and there is a small risk that the lens can get displaced and drop into the vitreous cavity. So whenever you're introducing the infusion cannula at this stage, always be mindful that reduce your bottle height now and then get in with your infusion followed by the cutter. The cutter is placed behind the lens. All the OVD and the muck which is there behind the IOL is then cut and aspirated. Now is the time to perform the optic capture if at all it's possible in this poor visualization scenario. But before that, I'm going to use diluted triamcinolone acetate just to check that I have not missed out any vitreous fibril. Thankfully, there is none. With the irrigation in my left hand, which is retracting the iris, I just tap the lens down and go and visualize this part. We can clearly see that the haptic is in the sulcus and the optic is slightly below the level of the orexis margin, and we can see this ovalization or this V shape at the optic-haptic junction, suggesting that the optic is behind the anterocapsule while the haptic is above the anterocapsule in the sulcus. Confirm the same thing in the opposite side is very difficult because of the pre-existing corneal opacity. Nevertheless, the lens seems to be quite stable. Time to close. The side ports are hydrated, intracameral antibiotics are placed into the eye. That's it, the case is done. So these are the first day post-op pictures, and thankfully they look decent enough. The patient has a visual acuity of about 618 and the intraocular pressure is 18. Patient is doing quite well and she's happy. So let's go back and see this case scenario wherein, of course, I just couldn't figure out why the PC tear happened. Maybe there was a forward bulging of the posterior capsule which was probably missed by me, and as I was trying to remove this bit of cortex, the posterior capsule ripped open and along with a vitreous prolapse. The important point to highlight from this case is that it might be challenging to place the haptic in the sulcus, especially when the pupil is small. Because the visualization is compromised, I'm not able to see the rexus margin. So I'm assuming that the haptic has gone behind the pupil. If you have not created enough space between the capsule and the iris using a cohesive OVD, then there is always a risk that the haptic can slip under the anterocapsule. And if it slips under the capsule, there is always a risk of it sinking down, which almost happened in this case. So it's quite a challenge to place the haptic in the sulcus when the pupil is small. It's important to retract back, see well, and then place it. So that was it. Thank you for watching and hope you found this helpful.